Medical problems of adolescents, specifically obesity and sleep. And obesity itself is a huge subject, so I'm going to make sure I can try and get all this in 20 minutes. So it won't be as comprehensive as I would like, but you'll get an overview of both of these subjects. So this is the objectives we're going to look at for obesity as well as sleep. And we're going to start with obesity. Obesity is a public health epidemic. As a result of that, all adolescents are at risk for obesity and should be screened. There are three focus areas that we're going to look at with obesity. We're going to look at prevention, assessment, and treatment. And while we look at treatment, some of the things to think about is that science continues to lag behind the obesity epidemic. So there are many gaps in evidence-based recommendations. So some things are suggestions. So BMI measurement is the recommended screening test for obesity. It's an important screening tool, but it must be integrated with other information in the health assessment, like the patient's family and medical history, a review of the BMI trajectory, diet and activity habits, and appropriate laboratory tests. And when we're looking at BMI 85 to 95 percentile, depending on the health assessment, some of these adolescents may receive preventative counseling, where others may receive more active interventions. And when we're looking at BMI of 95 percentile or above, they're likely to have obesity-related health risks, and so they should be encouraged to focus on weight control practices. So providers can provide obesity prevention messages for most adolescents. And then those that have excessive weight, they would do control interventions. But here are the prevention messages, and I'm sure many of you are familiar with these. At the bottom are some suggestions. They're not evidence-based, but the American Academy of Pediatrics suggests these prevention measures. Diet rich in calcium and high fiber, and 60 minutes of vigorous physical activity per day. So when an adolescent comes in and their BMI is greater than 85 percentile, the health provider should assess medical and behavioral risks before initiating any intervention. And when we're looking at the medical assessment, we're looking at monitoring the body fat assessment, which BMI is the gold standard for that. We're also looking at parental obesity. Parental obesity is a strong risk factor for adolescent obesity persisting into adulthood. And we're also looking at family medical history. So is there a family medical history of type 2 diabetes, hyperlipidemia, and hypertension? We are also assessing for weight-related problems, and I'm sure many of you know what these are. In the PowerPoint under the notes, I have some of these listed and what you would be looking for these various conditions. But to mention a few, we have hypertension, so blood pressure at every visit. If there's a reading of 3 or more that is greater than the 95th percentile for either systolic or diastolic, then you're looking at problems with hypertension. Type 2 diabetes, so we're getting fasting glucose levels every 2 years with that. Also, some other weight-related problems are obstructive sleep apnea, non-alcoholic fatty liver disease. Reflux is exacerbated by obesity, hyperlipidemia, depression. Muscle and joint issues are also seen in the obesity. And acanthosis is also seen in obesity. So when we're assessing for these other related problems, some areas of focus in your review of systems and in your physical exam are listed here on this table. And so you see when you're looking at the review of systems, some of the red flags that you are looking at to say, hey, they may have some other related problems because of this obesity, as well as the family history in the physical exam here. And then in the last column, we have the lab tests. And there's currently insufficient evidence to recommend for or against lab screening, but a consensus-based screening has been established. If there's presence of risk factors like BMI greater than 95 percentile. There is a patient history of hypertension, dyslipidemia, or smoking. If acanthosis is on exam, if there's a family history of type 2 diabetes, dyslipidemia, or cardiovascular disease. And so if a patient comes in and their BMI is greater than 85 percentile, then they are all getting fast lipid profiles. But if they are at 85 to 94 percentile, and they have other risk factors that you find in this review of systems, family history, or PE, then they are also getting fasting glucose, ALT, and AST levels biannually. If they're greater than 95th percentile for BMI, and regardless of risk factors, they are not only getting that lipid profile, but they're also getting the fasting glucose, the ALT, AST levels biannually. Another screening that's important to mention is depression screening in obesity patients using the PHQ-9. Not only just assessing for their mood and what management may need to be done for that, but evidence shows that patients with depression are less likely to adhere to recommended management plans and less likely to be effective in self-management of chronic conditions. So depression screening is important to get. So when we look at treatment of obesity, what we want to do is improve the weight for height disproportion through either weight loss or through weight maintenance during linear growth. And we also want to improve long-term physical health through permanent healthy lifestyle habits. And as we talked about last time, in adolescence, they're forming a lot of those lifestyle habits that they're going to carry into adulthood. So we want to improve those. So here's an algorithm of prevention and treatment management for different BMI percentiles. So if you look at the 5 to 84 percentile, they go straight to the prevention area of this algorithm, and where you're looking at identifying problem behaviors and targeting those, or praising them for whatever they're doing right currently, and also just reviewing any risks that they may have. When you go to the 85 to 94th percentile, if there's no evidence of health risk in your assessment, then you're moving again up to the prevention area of this algorithm. But if there is evidence of health risk, then we're going down into the interventions for treatment, which is in 4 stages. Also, the group that is greater than 95 percentile BMI, they also start at that stage 1 of the intervention for treatment. And so stage 1 is prevention plus, stage 2 is structured weight management, 3 is comprehensive, and 4 is tertiary. And what we're going to do is just talk about stage 1 and 2, because those are the 2 that are done primarily in the office and not in other weight management programs. So the first one here is stage 1, is the preventive plus. You're going to be meeting more frequently with the adolescent to motivate them for change. You're going to work with them, you're going to work together to identify behaviors, and you can see the behaviors here on the right that are appropriate to target. And these behaviors may need to be changed in degrees or steps, not all at once. So if you're looking at consuming 5 servings of fruits and vegetables every day, and maybe your adolescent isn't eating any fruits or vegetables, they're not going to go straight to 5. Maybe they'll have a fruit or vegetable with lunch and with dinner. And then next time you meet with them, maybe they'll incorporate more than that. Or if they're drinking 2 liters of Coke every day, maybe let's drink 1 liter of Coke every day. So things happen in degrees and steps in this prevention plus area. Now, if you've been meeting with them for a while, and what the guidelines say are 3 to 6 months, you may want to move up to stage 2, which is a structured weight management. And what makes this different than stage 1 is there's more support and structure provided. It requires getting a dietitian or another clinician involved who's received additional training in creating these kinds of eating plans. You may need to refer to social work for counseling, or refer to physical or exercise therapy, depending on what is going on with the adolescent. And these visits are monthly, so it's more structured, there's more support. And if you look here on the right at what those behaviors are, you have a planned diet, you're structuring more of their eating, you have planned and supervised more physical activity. So it's a little more, again, structured than stage 1. So what works with adolescents? So comprehensive programming works with adolescents. When you're taking care of them, you want to consider the role, not just the adolescent themselves, which the adolescent being the primary focus works with this type of treatment, but also consider the role of the family, consider cultural values, consider their school and their community that they live in. And another thing that works with adolescents, of course, is peer involvement. And so that can help with whatever treatments or things that you are putting in place to get peer involvement, to get their buy-in. So counseling strategies, we're back to motivational interviewing again. Okay, so this patient-centered counseling technique helps the adolescent identify their own motivation for making change. It takes into account the patient's readiness to change. It also uses non-judgmental questioning and reflective listening to uncover the beliefs and values of the adolescent. And by eliciting the concerns of the adolescent, the health provider can evoke motivation rather than try to impose it. And then help the adolescent formulate a plan that is consistent with their own values and something that they will follow through on. Other techniques you're looking at are cognitive and behavioral techniques. You want to initiate goals that should be achievable. So like we said, if the adolescent is drinking 2 liters of Coke a day, maybe they only drink a liter. And then you want to reinforce behavioral goals rather than weight goals. So if they're able to achieve that number of vegetables, or they're decreasing their amount of sugared beverages, looking at reinforcing and praising them for that rather than if there's been a change in their BMI.
All right.
We also want to focus on the successes and not the failures. Okay. So that is obesity in a nutshell. And now we're going to move on to sleep. So the National Institute of Health has identified adolescents as a population at high risk for problems of sleeplessness. In Healthy People 2020, they have a goal to increase the proportion of students in grades 9 through 12 who get sufficient sleep, and this is defined as more than 8 hours in a 24-hour period. The American Academy of Pediatrics supports childhood sleep guidelines, so that adolescents should get 8 to 10 hours per 24 hours of regular sleep to promote their health. But what they have found is that, according to many of these statistics, is that adolescents are just not getting enough sleep. They are missing about 12 hours of sleep during the school week. They try to catch up on the weekend, but they can't catch up on 12 hours in 2 days. So what factors are contributing to insufficient sleep? Well, one factor is biological. It's the circadian rhythms. So as a child reaches adolescence, their rhythms tend to shift, and they naturally feel more alert later at night and wake up later in the morning. And also during this time of adolescence, there's increased metabolism and rapid growth, and so they just need more sleep. The need for sleep increases. So what they find in our teens are sleepy at times where they should be fully awake, like at school or home or driving. Some other factors that are contributing to this, to lack of sleep, are electronic media. And exposure to this in the evening has the potential to disrupt sleep. And it depends on, they're saying it may be due to the light that is produced by this electronic, or it may be due to the content of the screen time, that it can have an impact on the mental, emotional, and psychological arousal, physiological arousal. The other factor that is contributing to sleeplessness is caffeine. There's increased consumption of coffee and energy drinks, and they've been shown to disrupt sleep. Caffeine has. And when you're addressing caffeine with the adolescent, you have to determine, is the adolescent turning to caffeine because of insufficient sleep and inconsistent sleep? Or does the caffeine, is that what is causing the sleep issue itself? Some other factors that are contributing to sleeplessness is school start times, chronic and medical illnesses, mental health issues, and some over-the-counter and prescriptive medications. So when you get enough sleep, this is what it improves. And so this is when you're having a good day. You have an increase in your quality of life, your behavior, your moods, your health in general. But when you get lack of sleep, and I'm sure many of us have experienced this before, you have limits in your ability to learn, listen, concentrate, and solve problems. It contributes to unhealthy eating habits, can contribute to depression, aggressive and inappropriate behavior, increased use of stimulants, alcohol, and other similar substances. And there's an association, like with the depression, between negative moods and more pronounced sleep-related issues. So sleep can affect many areas. Some specific areas that it impacts for adolescents is with school. So more than 1/2 of high school seniors go to bed at 11 p.m. or later at night. And then regardless of age or grade, they wake up around 6:30 or before then to be in school in the morning, because most high schools start around after 7 o'clock, before 8 o'clock in the morning. And so this leaves many of those students with inadequate periods of sleep. And then on the weekend, the adolescent sleeps longer than they do during the school week, but they're not getting enough to catch up on their amount of sleep. So then when they're in school, they're not able to pay attention, to learn, to concentrate, and it causes those other negative effects that we saw on the previous slide. And then one of the most troubling consequences of sleepiness are injuries and death related to lapse in attention and delayed response times at critical moments while driving. So you see the impact is drowsy driving, which becomes a problem with adolescents. So how are we evaluating sleep? So you're asking the questions, when do you go to bed? Not only when do they go to bed, but when do you actually fall asleep? And do they sleep through the night? When do they wake up? And then what does their weekend sleep schedule look like, and how much does it deviate from the weekday schedule? So some sleep strategies that you can offer to adolescents is making sleep a priority, developing a routine, making their bedroom a sleep haven, watching their caffeine intake. And so when they're watching their caffeine intake, they may want to stay away from caffeine after lunch or around noontime, just because of the half-life of caffeine in the system, so it does not disturb that nighttime getting to bed at night. Consistent bed and wake times, including weekdays, weekends, and vacation. And if they're going to deviate from those times, it should only be about by 1 hour of deviation. Turning the screens off 30 minutes to an hour before bedtime. Early afternoon naps, maybe if the adolescent comes home from school in the early afternoon, they would like to take a nap, just limiting that nap to 45 minutes so it doesn't disturb going to bed at night. Also, sleep aids may be used depending on the severity of the sleep problem and also the etiology of the sleep problem. So if the sleep problem is due to chronic medical illness, mental health issues, or because of some medication that the teen is taking, then you may find sleep aids are needed, like melatonin or other prescriptive sleep aids. And what is important to really just educate adolescents and their parents about the importance of sleep, that this is a problem with adolescents and it should be addressed, and giving those strategies for sleep, that sleep hygiene. So these are the references used, and any questions?
Great, thank you so much, Lydia. We'll open it up to questions, please. If you would take your sound off of mute, that would be great. You certainly can chat if you'd like.